welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Abby Mason, who is a PGY2 critical care resident at Erlanger, who'll be presenting on the efficacy of targeting high mean arterial pressure for older patients with septic shock, a multi-center, pragmatic, open-label, randomized controlled trial.
Thank you for the introduction. I'm happy to be here today, and thank you for everyone for taking your time out of your day to listen to these journal clubs. Before we get started, I don't have any disclosures to make about this presentation or the article that's being discussed. And for your reference, here are the abbreviations that will be utilized throughout the rest of the presentation. For objectives, we're going to describe the rationale for evaluating a higher MAP target, specifically in older patients with septic shock. We're going to also summarize the design, the methodology, and key findings of the OPTPRESS trial. And we're going to evaluate the trial's strengths, limitations, and applicability to clinical practice. So before we start, let's start by briefly reviewing the pathophysiology of sepsis. Sepsis begins with a dysregulated host response to infection that triggers widespread inflammation and immune dysregulation and endothelial dysfunction. There can also be coagulation abnormalities. So this cascade leads to capillary leak, vasodilation, and impaired oxygen delivery, which accumulates in organ dysfunction. In septic shock, this can escalate, leading to circulatory collapse, which is usually driven by the profound vasodilation and often compounded by myocardial depression and microvascular dysfunction. So with those in mind, how do we define septic shock clinically? So according to the sepsis 3 definition, septic shock is a subset of sepsis with profound circulatory, cellular, and metabolic abnormalities associated with a higher risk of mortality. And clinically, it's diagnosed when a patient with sepsis requires vasopressors to maintain a MAP that is equal to or greater than 65 millimeters of mercury and has a lactate greater than 2 millimoles per liter despite adequate fluid resuscitation. So once we've started vasopressors and a patient is ideally optimized from a fluid perspective, we then turn our focus on making sure that we have adequate perfusion pressure, which leads us to the question of what the ideal MAP is to ensure that we do have adequate perfusion. So to answer that, we need to discuss what a MAP is, or what MAP represents, and why it's so essential in septic shock. So MAP is calculated as a diastolic blood pressure plus 1/3 of your systolic minus diastolic blood pressure, and it reflects the average perfusion pressure across the entire cardiac cycle. So importantly, MAP is the surrogate we use to estimate blood flow to the vital organs, but the pressure needed to have adequate perfusion isn't the same for every organ system. In patients with chronic hypertension, there's often a rightward shift in their autoregulatory curve, meaning that they may need higher pressure to maintain the same organ perfusion. Current guidelines from the Surviving Sepsis campaign recommend targeting a MAP of greater than 65 or equal to 65. And while increasing MAP may improve perfusion, it comes as a risk of higher vasopressor exposure, which has its own consequences. So we'll talk briefly about some of the prior studies that explore different MAP targets in septic or vasodilatory shock and laid the groundwork for this trial, the OPTPRESS trial. Sepsis PAM compared MAP targets of 65 to 70 versus 80 to 85 millimeters of mercury. It didn't find any mortality difference overall, but improved renal outcomes were shown in some hypertensive patients. The downside that is that it also showed higher rates of atrial fibrillation in the high MAP group. The 65 trial enrolled older ICU patients with vasodilatory shock and utilized a permissive hypotension strategy. Again, there's no mortality difference, but a signal that patients with chronic hypertension may benefit. And the Ovation trial was a small pilot trial, but it did show that a lower MAP may reduce mortality in elderly patients. So we also know that vasopressors aren't benign. A 2022 prospective cohort study showed that for every 10 mics per minute increase in norepinephrine equivalents over 24 hours, and there was a 33% increase in 30-day mortality. So your adverse effects from vasopressors include arrhythmias, ischemia, especially digital and mesenteric, tissue necrosis, and potential immunosuppression. And this may be especially relevant in elderly patients who have less vasculature reserve or more comorbidities. There are also special considerations to have with older patients in septic shock. First, aging brings structural changes like arterial stiffening, impaired barrel reflexes, and altered autoregulation. And these patients might not tolerate hypotension the same way that like a healthy 40-year-old would. 2023 British Medical Journal review calls out how sepsis guidelines often underrepresent frail and elderly patients and recommends individual MAP targets in this group. And lastly, many older patients have chronic hypertension, which does shift that autoregulatory curve like we discussed. The OPTPRESS study was conducted in Japan, which has a 66.9% rate of hypertension in patients that are greater than 65 years old. So the authors designed OPTPRESS to answer a specific question, which is, does a higher MAP target improve outcomes in elderly patients with septic shock? And this study was conducted in Japan, which has a large aging population. And in this cohort, chronic hypertension is relatively common. And importantly, early trials like sepsis PAM had a mean MAP in the control group above the intended range. The average MAP was 75 millimeters of mercury. And this limits the ability to draw clean conclusions from this study, which has given them like mixed results about what the ideal MAP target is in these patients. So we'll jump into the study now. This was published in the Journal of Intensive Care Medicine in May of this year. The primary objective of OPTPRESS was to evaluate whether targeting a higher MAP of 80 to 85 in patients aged 65 years or older with septic shock would improve 90-day all-cause mortality compared to a standard MAP target of 65 to 70. So this study included patients that were aged 65 years or older, a diagnosis of septic shock based off of the sepsis 3 criteria, and were admitted to the ICU. They excluded patients who received more than 3 hours of vasopressor use before enrollment, cardiac arrest, were diagnosed with COVID-19, and patients who required a stricter blood pressure control. OPTPRESS was a multi-center, pragmatic, open-label, randomized controlled trial, and it was studied across 29 different ICUs in Japan. The patients were randomized to a high MAP target group with a goal of 80 to 85, or a standard target MAP group with a goal of 65 to 70. Their target was maintained for 72 hours, or until vasopressors were weaned off, whichever came first. One key protocol element that early vasopressin was added when the norepinephrine dose exceeded 0.1 mics per kg per minute, and it was able to be titrated up to a max of 0.04 units per minute. And this was designed to reduce catecholamine burden, which has been suggested to contribute to the adverse outcomes seen in previous studies. The primary outcome was 90-day all-cause mortality, and secondary outcomes included 28-day mortality, sepsis-related mortality, organ support free days, lactate clearance, a frailty score, changes at 90 days, and major adverse kidney events. For safety, they tracked arrhythmias, ischemic complications, thromboembolic events, hemorrhagic events requiring transfusion. The authors planned to enroll 836 patients, but the trial was actually stopped early after an interim analysis showed potential harm with a high MAP group, and the final sample size was 518 patients. The primary analysis was done using an intention to treat approach and used the Fisher's exact test for 90-day mortality. They also did a per protocol analysis, adjusted logistical regression, and post hoc multivariable modeling to address any baseline imbalances. And a p-value of less than 0.05 was considered statistically significant. So let's jump into the results. A total of 561 patients were randomized. 258 were assigned to the high MAP group and 260 to the standard MAP group. After protocol violations and technical exclusions, 242 and 246 patients were included in each per protocol group respectively. Both groups were well balanced at baseline. The median age was around 78 years with a slight male predominance in both groups. Importantly, 53% of patients in each arm had chronic hypertension, which is a key subgroup of interest, particularly in this study. The baseline SOFA scores were similar, which is 10 in the high target group and 9 in the control. Lactate levels and MAPS randomization were also well matched. And the sources of infection were typical for septic shock, primarily abdominal, urinary, and pulmonary. So the study was stopped early after an interim analysis showed significantly higher mortality in the high MAP group. The 90-day all-cause mortality was 39.3% in the high target group, seen here in the blue column, and versus 28.6% in the standard MAP group. And that's an absolute risk difference of 10.7% with a p-value of 0.012 and a confidence interval that did not cross 1. So this result is statistically and clinically significant. Mortality differences were also significant in all major secondary endpoints. So sepsis-related mortality, 90 days seen at the very top, was 30% in the high target group in the blue row versus 17.8% in the control group in the orange. Sepsis-related mortality at 28 days was similar, with 24.1% in the high target group versus 16.2% in the control group. In 28 days, all-cause mortality was 30.4 in the high target group versus 21.6 in the control group. There are no subgroups, including those with chronic hypertension, where a higher target MAP showed a mortality benefit. The higher target MAP also had significantly fewer organ support free days across all three major metrics. So the high target group had 16 days free of catecholamines starting at the top versus 19 in the control group. The high target group had 15 ventilator free days compared to 18 in the control group. And the high target group had 18 days free of renal replacement therapy compared to 19 in the control group. And there was no significant difference in lactate clearance, frailty score, or major adverse kidney events. And while the hard target MAP group had numerically more safety events, none of the safety outcomes reached statistical significance. Still, the trend aligns with increased vasopressor exposure and potential adverse effects, even if the study wasn't powered to detect them. So for hemorrhagic events, ischemic events, and the presence or the occurrence of any arrhythmia, none of those reached statistical significance. That's also important to note that this study did not reach its full accrual due to it being stopped early. So the study was not powered to detect these differences. And it's also worth noting that vasopressors were used for 23 more hours on average in the high target MAP group, and total doses of norepinephrine and vasopressin were significantly higher as well. The authors concluded that targeting a high MAP of 80 to 85 in older patients with septic shock increased 90-day mortality compared to the standard target of 65 to 70. Notably, there was no benefit in any subgroup, including those with chronic hypertension. And the high target MAP strategy led to greater vasopressor exposure, fewer organ support free days, and higher rates of adverse events. And despite early vasopressin use to reduce catecholamine toxicity, the high target approach was shown to be harmful. So the strengths of the study was that it was a multi-center and pragmatic controlled trial. It had good external validity. It was enrolled a clearly defined clinically relevant population, and baseline characteristics were well balanced. The use of protocolized vasopressin is a novel strength compared to other studies that left vasopressin initiation up to the discretion of the provider. Some of the limitations of the study was that non-invasive blood pressure monitoring was used, and as well as it being open label. The vasopressor titration itself was left to the discretion of the provider. And there's no strict algorithm when to add different vasopressors or what to increase them to. The MAP in the control group often exceeded the goal range of 65 to 70. And finally, the trial was stopped early, so it's possible that the full sample size would have yielded slightly different results. So in conclusion, the OPTPRESS trial adds strong evidence against targeting higher MAPs in older patients with septic shock, even those with chronic hypertension. And this challenges prior hypotheses from Sepsis PAM, which suggested that high MAP strategies might help kidney perfusion or outcomes in hypertensive patients. OPTPRESS aligns more closely with the 65 trial, which showed no benefit of permissive hypotension, but no harm either. And it also aligns with the surviving sepsis guidelines, which recommends a MAP greater than or equal to 65 millimeters of mercury. And so in conclusion, that for older patients, a standard MAP target is safe, and pushing a higher MAP may actually do harm. Thank you. I'm open to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.